on the word on him. We'll go ahead and get started. So starting today, we're kind of separating ourselves from bacterial infections and we're transitioning into some other type of infections. The first one we're going to start talking about are invasive fungal infections. And before we can have a brief discussion on invasive fungal infections, I think we need to just spend a little bit of time looking at some of the differences that exist between fungi and bacteria, fungi, and then the mammalian host that they're infecting. That'll help us identify the targets of antifungal drugs that are in clinical use. We'll learn a little bit about the chemistry and the mechanisms of action for these antifungal agents, the good things that they do, the bad things that they can do. No good deed goes unpunished, and that holds true with the antifungals. And then as we progress today, we'll talk about 3 different fungal infections that are relevant in society today. Realistically, the list of fungi that can cause infection is pretty broad. There's a lot of fungal pathogens out there, but again, trying to keep consistent with the course, common things are common. So I want you to be able to articulate the drugs of choice for 3 particular fungal infections that you might get asked about when you go out on rotations. Okay. Before we get into the content, just really quick, the exam was last Wednesday. The average was really nice, so good job. That was nice to see. You guys spent some time preparing. Hopefully that lends to good understanding of that content. In talking with Dr. Lewis before class, we're just going to try and identify some time before next Friday whereby we can review content from exam 1, if that's your desire. Go over exam 2 as well, if that's your desire. In fact, I may just ask the group on Wednesday to fill out a sheet of paper indicating yes or no, you're going to take a golden ticket exam, and then what exam that might be to help us better prepare for things. So I can't speak for Dr. Lewis's schedule, but I will tell you that I will be here about 8:15 on Wednesday morning. If anybody wants to go over any of the questions from exam 1 or exam 2, and then I'll be here again Monday morning and Wednesday morning next week as well to help you guys solidify some content before we take the golden ticket exam on Friday. Okay. Comments, questions, concerns, and you'll join in as your schedule allows. Okay. All right. So for today, again, let's look at the fungal cell architecture, and then see if we can identify some molecular targets that would lend to this overarching concept of selective toxicity. We want to inhibit fungal cell metabolism without impeding that of the host. And then that'll lead into then this discussion on the classes of antifungals. I'll bring up some chemistry features, but if there's something specific about the chemistry of these drugs I want you to know, I'll make it obvious. Mechanisms of action. In large, I'd like you to be able to articulate the mechanisms of action. Drug interactions are pervasive with antifungals, especially a class referred to as the azole antifungals, and we'll explain why that happens. And then adverse drug reactions. These drugs, again, are fraught with some nasty things that they can do inside a person. And so when you start to look at fungi, and a fungal infection, and you compare that to a bacterial infection, bacteria have far more targets that we can interfere with because the architecture of their their machinery is so much different than that of the human host. When you start to look at fungi, though, it becomes a lot more difficult. The ribosomes that fungi have are very, very similar in composition and architecture to that of the human host. So we can't just give a protein synthesis inhibitor to shut down fungal cell protein synthesis. It's not that easy. We haven't identified that molecule yet. Fungi are eukaryotes, right? Now, they do have a cell membrane, much like we do, but what we'll make note of is that there are some subtle differences between the fungal cell membrane and constituents thereof relative to what we have in our cell membranes. And fortunately, fungi do have a cell wall. Now, that cell wall is not composed of peptidoglycan, right? Rather, it's composed of glucan polymers that we'll talk about in a minute. And fungi exist as parasites or saprophytes. So they live on dead and decaying matter. and consume that dead and decaying matter to generate energy for their reproduction, or they basically just live on you and feed off of you as a parasite. So if this is a representation of a fungal cell, and you take a little section of the fungal cell wall and membrane, and then you blow it up, this is what you might see. Okay? So starting from the inside and working out, we'll do it in this fashion. You see a lot of different business going on within this cell, or this little image from the cell. And the first thing I want to make note of is that fungi have machinery to replicate their DNA. They have machinery to make their RNA, and then they have machinery to make proteins. And that is very, very similar in composition to what we have. So we can't use protein synthesis inhibitors, RNA inhibitors, or DNA polymerase inhibitors in a fungal cell to inhibit its growth. So those are kind of off limits. But what we can perhaps do is identify subtle differences in enzyme composition that allows fungi to generate precursors for DNA synthesis. We can maybe shut down or impede or exploit some of those enzymes that lead to these precursors that may then impair the fungal cell's ability to make DNA and RNA. Right? And we'll come back to that later on. There is a very, very important cell membrane constituent that fungi have. Remember, in our cell wall, we have sterols. Our principal sterol in our cell wall is cholesterol. Fungi have cell walls which rely on the presence of sterols for fluidity, structure, what have you. The principal sterol in fungi ends up being ergosterol, not cholesterol, ergosterol. Ergosterol and cholesterol have a very, very similar, almost identical synthetic route up until a certain point where it diverges. The enzymes that are used to synthesize ergosterol and cholesterol from a nomenclature perspective are very, very similar, but there are differences in their structures, and we exploit some of these differences for the purposes of killing fungi. So right off the bat, if you know that fungi have ergosterol and humans lack ergosterol, that might be an interesting target to exploit, this ergosterol synthetic pathway. And so there's an enzyme that we can target for shutting down ergosterol synthesis or making aberrant ergosterols that damage the membrane. And then we work our way outward again to lipid bilayer. There's not much we can do about that membrane. That membrane in fungi represents or mimics our membranes. All right, it's a lipid bilayer. But again, we can exploit the presence of ergosterol in that lipid bilayer and maybe apply a molecule that has affinity for ergosterol for the purposes of destroying fungi. And then we get into this aspect of the fungal architecture, and this represents then the fungal cell wall. And the first part of the cell wall that I'll make mention of is this chitin layer. These little, I don't know what color that is, sort of like a light red color, rose color. That's supposed to represent chitin. And chitin is a polymer of glucosamine, basically. Yeah, when's the last time you stepped on a bug? Hopefully you don't have to do that very often, but when you step on a bug and you hear it go crunch, all right, that's that chitin. It's the chitinous exoskeleton of an insect. Right? That's a very, very thick layer in an insect. Now, fungi have a chitin layer as well. It's not nearly as thick as in an insect, but it does provide structure and protection for the fungal cell. It would be nice, perhaps, if we could identify a molecule that could inhibit the formation of this chitin. That might lend to some selective toxicity because you and I don't have chitin in our cells, in our body, okay? And this layer of chitin, while it's represented here as just basically 2 molecules in thickness. It varies from fungal species to fungal species, okay? Next up then, you have these blue and then these green polymers. And this represents then the major constituents of the fungal cell wall. These are these glucan polymers, and they're arranged in a beta 1,3 or a beta 1,6 fashion. So if you remember, like we have one glucose polymer, or excuse me, one glucose molecule and another glucose molecule. Here's the anomeric oxygen. The one position is just below the anomeric oxygen. If that anomeric position is connected to the 3 position on an adjacent glucose, that's a 1,3 linkage. If that one position is connected to the 6th position on an adjacent glucose, that's a 1,6 connection. So we have 1,3 and 1,6 beta glucan polymers that make up the fungal cell wall. In most fungi, I mean, by weight, this represents 50 to 70% of the fungal cell. So it's a major constituent of the fungal cell. As such, it makes sense. If we can figure out how to shut down fungal cell wall synthesis and impair or inhibit the synthesis of these glucan polymers, we can greatly reduce the strength, rigidity, and structure of the fungal cell such that it lyses and breaks open. Okay, so this is a major target of at least one class of antifungal drug. And then lastly, you have these manoproteins that are on the surface of the cell. We don't really have too much in the way right now. Actually, I think there's an investigational drug that might be close to or recently approved that interferes with manoproteins, not necessarily manoprotein synthesis, but the manoproteins in a fungal cell are important for the fungal cell's ability to adhere to epithelial surfaces for the purposes then of infection. So if we can interfere with manoprotein adhesion, you might actually decrease the ability of the fungal cell to infect. Okay. All right, just a little bit about fungal infections. I mean, we have superficial fungal infections. You've all heard of jock itch, athlete's foot. There's a lot of different superficial fungal infections. A lot of these can just be simply addressed with over-the-counter preparations. I have children. My children are athletes. My children have had athlete's foot. And I'm telling you, man, that spray stuff, I don't know what's in it. It might be clotrimazole, like boom, fast-acting, tinactin. The stuff works as long as you just use it. My poor daughter had athlete's foot. I mean, it's like, damn, girl, the heck? Wash your feet. It is what it is. Nonetheless, these superficial infections are largely caused by what we refer to as dermatophytes. And these particular fungal species, they like to eat on protein in and around your toes and between your toes and other areas. So these aren't really what I would call life-threatening infections, but from a cosmetic and just a personal hygiene perspective, yeah, they're important. Opposite to that then are systemic fungal infections or invasive fungal infections. And these can be fatal. I guess, I don't know if anybody reads the chapters that I post, but the last estimate was about 1.5 million deaths worldwide secondary to invasive fungal infections. That's a substantial number of deaths. So these are a problem, in particular in immunocompromised patients. So when you have a systemic infection, it's largely because there's something else going on. That patient has a risk factor. If that patient gets exposed to an opportunistic or an endemic fungal species, God bless you, once exposed, once inoculated, realistically, that fungal inoculum can travel to anywhere in the body. It can cause a bloodstream infection. It can get into the organs and cause a deep-seated infection. Invasive candidiasis, for example, is pretty common in select patients. So a lot of times, though, these are opportunistic. Yes, sir.
Do saprophytic fungi pose much of a threat?
Yeah, so from a saprophyte, I mean, where do you think you would encounter a saprophyte that would pose a risk? Where might you be that would lend to that exposure? Any thoughts? I mean, you guys have all walked through like the woods or the forest on a walk, or you see some tree branch that's just been there forever and it's covered in this stuff, right? I mean, so that's a saprophyte, basically. If you came across a carcass and it's dead, obviously, and it's decaying, that decay is secondary to some of these fungi that are in the environment. Chances are, if you just walk by it, no big deal. But if you're very curious and you start poking at things and then it kicks up and then you inhale it, then you're putting yourself at risk. You have an exposure. But remember, an exposure doesn't always lead to an infection. If you're healthy and you're exposed, chances are your immune system is going to take care of things before the fungi have a chance to infect you. We're not so worried about maybe you doing that, but now if you're on steroids or you're a chemotherapy patient or you have some other type of situation where you've compromised your immune system, then that becomes a problem because your ability to fight off that initial exposure is greatly diminished, and then it can take effect, cause an infection. Good question. And the endemic fungi are the ones that we really worry about. I'll make mention of 3 of those. Endemic fungi in the United States primarily exist in 3 areas: Ohio River Valley in our area, then out in the Southwest. Individuals who aren't immunocompromised are at risk for infection, and it's often a self-limiting infection. But again, it goes back to creating that ideal situation where you have a risk factor immunocompromised somehow. That's when it gets bad. Right? And on that topic, here's some common causes of systemic fungal infections. When you look at coccidioides, blastomyces, and then histoplasma, I mean, these 3 represent then the endemic causes of fungal infection. So they're in the environment already. Histoplasma and blastomyces from the East Coast all the way over just past Kansas, and then as far north, probably as Minnesota, represent an area where those 2 fungi are endemic. And then as you travel out into the more drier climates in the Southwest, coccidioides, it's called valley fever. I think there was an interesting House episode about this, if anybody watched House. Coccidioides is endemic out west, and I think if there's a strong wind, I think there was a report of an earthquake, a small earthquake happening out west that led to a significant amount of exposure of coccidioides. That can cause infection in otherwise healthy individuals. Contrary to that, Candida, Aspergillus, and Cryptococcus, those 3 fungi represent probably 80% of all the fungal infections that you may encounter throughout your practice time. Candida comes in a lot of different flavors, and it's probably one of the most common causes of invasive fungal disease in hospitalized patients in particular. Aspergillus is a mold. It comes in a variety of different flavors as well. And Aspergillus is notorious for infecting individuals who have just undergone some type of transplantation. And then Cryptococcus neoformans, and then Cryptococcus gattii. These are 2 yeasts that have a propensity to infect individuals who are immunocompromised. Cryptococcus neoformans, this was very, very devastating for individuals during the HIV/AIDS crisis, before we knew how to prophylact against cryptococcal infections and before we knew how to treat patients with highly active antiretroviral therapy. A lot of patients died because of cryptococcal meningitis just because we didn't know how to prophylact them or treat them. Right. So on that topic, risk factors. So what are risk factors? What are the risk factors for those superficial infections? Again, to athletes, sweaters, if you will. People that sweat a lot, engage in activities that causes profuse sweating, yet they don't have good hygiene, increases then the risk of developing a superficial fungal infection. And again, too, It's not that difficult to transmit fungi from one subject to another, or from one object to yourself, or from yourself to yourself. So sometimes you create a good environment for fungi to thrive. And then disturbing the normal flora. Again, too, our body is full of bacteria, our body is full of fungi, and you'd like to think that there's a homeostasis that exists. However, when you introduce something, a scenario or another drug that disrupts the natural flora, what that does is that creates then real estate for something that doesn't normally grow there to move in and start replicating, right? The best example, of course, may be with antibiotics. When certain individuals take antibiotics, that kills off the natural flora, in particular in the vagina. And when you kill off the natural flora in the vagina, what you do is you create an atmosphere or an area where candida can set and overgrow, causing vaginal candidiasis. Why do we tell patients who are taking corticosteroid inhalers for asthma to rinse their mouth out afterwards? For that very reason. The steroid has the ability to then disrupt the natural flora in the mouth, predisposing those individuals to oral thrush or oral candidiasis. And how many of you guys have dispensed nystatin suspension to a child? Where it's like, what, 1 ml on each side of the cheek 4 times a day or something like that. Well, the child is probably breastfeeding, and the child probably got some candida from mom's breast into their mouth, and the child doesn't have a developed immune system to fight that off. So you end up with those white patches in the mouth, which represents thrush. Excuse me. Systemic or invasive infections, who's at risk? Without a doubt, anybody that you can think of that's taking any type of medication which compromises the immune system is going to be at risk for systemic fungal infection. Okay. TNF alpha inhibitors for, say, Crohn's disease or IBD, anything that might be being used for rheumatoid arthritis, steroids, oral steroids. How much per day and how long do you think someone needs to really be on a steroid before they're at risk for a systemic infection? How much steroid does it really take? I don't know if there's a bona fide answer to that question because everybody's different. But what I have heard mentioned by experts in invasive fungal infections is about 20 milligrams per day times 30 days. That much steroid ends up being a risk factor then for invasive fungal infections. And then environmental exposure, we kind of made mention of this. Coccidioides out west, blasto and histo here, closer to us. And then nosocomial infection. Nosocomial infection. You go into the hospital, into the ICU or a critical area of the hospital, and you have lines put in you, that's a risk factor. A central venous catheter is a risk factor, okay? Being catheterized, urinary catheters is a risk factor, right? Any type of gastrointestinal procedure, surgery is a risk factor. The administration of total parenteral nutrition is a risk factor. Right? Anything that compromises the integrity of the gut is a risk factor. Broad spectrum antibiotics is a risk factor. Okay, so you go to the hospital technically to get better. The candida, which represents the majority of infections in the hospital, often due to Candida albicans, and we have Candida albicans pretty much all over us, especially in our GI tract. Okay, so patients who have an albicans infection, they probably gave it to themselves in one way, shape, or form. However, a lot of you have probably heard of Candida auris. Have you heard of Candida auris? When you get a second, you probably should Google this or just look into it a little bit. Candida auris represents a relatively new species of Candida that was identified several years ago from the ear of a patient in Japan. And what's been discovered about this particular species of Candida is that it's very, very resistant to a lot of drugs. It's resistant to the drugs that we would typically rely on to kill Candida infections. Candida auris is nasty because it can form biofilms very easily. It exists on the surface and it spreads to surfaces very, very easily. So there's a lot of what we would refer to as fomite contamination in the hospital, the doorknobs, the bed railings, you name it. If a patient has a Candida auris infection and it's on them, they're spreading it around into the environment. What that means is that other people and then other patients, incidentally, are going to come into contact with Candida auris, and transmission occurs in that regard, not necessarily from themselves to themselves. So that's a nasty one. Fortunately, we don't have a high incidence of Candida auris here in the United States, but we do need to be aware of how to treat it, and we'll talk about that later on. All right, questions so far? Questions or concerns? All right, targets of antifungals. So just out of curiosity, can you guys name a couple antifungal drugs that you're familiar with, whether you work in a hospital or a retail setting? Sir. Thank you. Another. Thank you. Another. Who can? Thank you. Another. Vori, is that what you said? Okay, thank you. Any more? Turconazole. All right. Another one. We got these azoles down. Not there, but there and there. We got a micafungin. So that takes up 2 spaces. Other antifungals. Nystatin. There's a good one. Thank you. Others. Lotrimin. What is in Lotrimin nowadays? It was clotrimazole when I was young. Is it still clotrimazole or did they reformulate it? Or is that Lamisil I'm thinking of that was reformulated? I don't remember. Okay, clotrimazole. All right, good. Now, where does a drug like nystatin go on this list? Any idea? You've dispensed nystatin. You've put that label on that tube and said, apply twice a day for a week, blah, blah, blah. All right. What is that nystatin that you're dispensing doing in that patient? Okay. Ergosterol synthesis. That's not correct. 10 push-ups. All right. In fact, nystatin is going to go up here under membrane function. Okay. That's good though. Good start. Okay. We got this one called micafungin. Micafungin has a couple friends that aren't listed on the screen, but where does this micafungin molecule go? You ever look into the mechanism of this one? Nucleic acid? Okay, that's a good guess. But when I tell you that micafungin is a large cyclic peptide that's got a lipophilic tail on it, that might change your cell membrane. In fact, we're going to put it here. Micafungin belongs to a class of drugs called echinocandins. And echinocandins, we'll look at this, you're going to come to realize inhibit cell wall synthesis in fungi. Okay, good. So we got membrane function. We got cell wall synthesis. Where do these azoles go then? Do azoles inhibit nucleic acid synthesis, cholesterol synthesis, or are they ergosterol synthesis inhibitors? So the azoles as a class inhibit ergosterol synthesis or impair ergosterol synthesis. Excuse me. These other two are, excuse me, less known molecules. We only have one molecule currently available that is used to inhibit or impair nucleic acid synthesis in fungi, and that's called flucytosine, or oncoban is the trade name. And then lanosterol synthesis. Lanosterol is a precursor to ergosterol. There is a drug on the market called Lamisil or terbinafine. It's an allylamine derivative. It's not used for systemic fungal infections. It's largely used for toenail infections. So I'm not going to spend a lot of time talking about this molecule because we just don't use it for anything systemic. But you should be aware of it. It's there for completeness, if nothing else. Okay, so that represents the armamentarium antifungal wise that we currently have. And we'll address them in this order. So the first one that we're going to talk about then are polyene antifungals. And nystatin was already mentioned. The trade name of nystatin, if it matters to you, is mycostatin. But then there's another molecule that is regarded as a polyene whose trade name is fungizone, and this molecule is called amphotericin B. So those are the two polyenes. And of the two, amphotericin is really the only one that's used in the hospital for the treatment of systemic fungal infections. Nystatin is relegated to topical administration for the most part for some of those less severe fungal infections. So what do we know about amphotericin B? For many, many years, this was the drug. Amphotericin B was the mainstay of therapy for systemic or invasive fungal infections. It's got a very, very broad spectrum of action. It's very efficacious, but it's fraught with a lot of toxicity. Regardless, it's still used today, not so much in its conventional form, but derivatives have been synthesized and approved for a while now that are far less toxic relative to conventional amphotericin B. Nystatin, again, we only use this topically. It's far too toxic to give it systemically. We can't inject nystatin into an individual and not hurt the kidneys very, very badly. So as such, we only use it topically. Regardless, both of these molecules are amphipathic molecules, and their target ends up being the fungal sterol ergosterol. It doesn't necessarily want to inhibit ergosterol. We want ergosterol to be present in the cell membrane of a fungal cell, and ergosterol serves as sort of the homing beacon or the target then of these polyene antifungals. So nystatin is shown here in a ball and stick conformation on the right. And then amphotericin B is shown here on the left. And what you can't appreciate necessarily from this image right now is the rigidity that is induced in amphotericin secondary to the existence of 7 consecutive double bonds relative to 1, 2, 3, 4 double bonds in nystatin, an area of saturation, and then some additional double bonds. That area of saturation, the lack of double bonds in this pink right here in nystatin, creates a little bit more ability of nystatin to bind not just ergosterol, but nystatin will now have a higher propensity to want to bind to cholesterol. And cholesterol is pervasive in all of your cells. So if you inject somebody with nystatin, it'll seek out the ergosterol in the fungal cell, but it'll also start to seek out cholesterol in your cells and start binding them and exerting its mechanism. So that double bond, we have a heptene configuration here in amphotericin, and those seven consecutive double bonds create that rigidity that's important for the functionality of amphotericin. Binding to ergosterol is facilitated by all of those double bonds. So this is sort of like a lipophilic side, and then this is a hydrophilic side in this amphipathic molecule. So when I say that, you have a lipophilic side and then a hydrophilic side, what's already starting to, percolate in your mind about how this drug might work mechanistically? Let's have a look. Mechanism of action wise, we'll pretend that here is an ergosterol, and then here is an ergosterol. And we know that ergosterol and steroids in general are lipophilic. And then here is an equivalent of amphotericin. And then here's another equivalent of amphotericin. So amphotericin, by virtue of hydrophobic interactions, is binding nicely to ergosterol in the cell membrane. And what ultimately happens then is that these are going to come together in probably more like a tetramer form in the cell membrane and create this nice pore in the cell membrane. And what we're going to start to see is a lot of stuff start leaking out. Nutrients, cations, other critical substances that the fungal cell is relying on all of a sudden start to leak out of these pores that have been created secondary to the exposure of these poly-E antifungals. And it's going to lead to then some fungal cell death. So these are pore-forming antifungals. And here's a different look at it if you prefer a better picture. There's ergosterol again, and then there's ergosterol. Here's amphotericin. Lipophilic interactions. We have a hydrophilic center to allow then hydrophilic substances to exit, and then that can be rapidly fungicidal. And just another picture. If you're like me, I like the pictures. I learn from pictures. Where do we use amphotericin? Where is amphotericin used clinically? We can use it for Candida. We can use it for aspergillosis. And we can use it for Cryptococcus. So those are three clinical uses of this particular molecule. But I will tell you that when we're starting to use amphotericin, its primary use up front is going to be for cryptococcal infections. We just have better drugs right now for Candida and aspergillosis. So if you have refractory Candida or refractory aspergillosis, you might employ the use of amphotericin. Cryptococcus is where you're going to really see it. It does retain activity against blastomyces and then histo as well. Okay. Now, limitations of use. What's the problem with amphotericin? So renal dysfunction it's not a matter of if it's going to occur, it's just a matter of when is it going to occur. And up to 65% of the patients that get amphotericin are going to get some degree of renal impairment. All right, some renal markers are going to change. Azotemia is going to happen, and it tends to be a time on therapy phenomenon. The longer a patient's on amphotericin, the more likely it is that they're going to develop renal function. And if they're left on it, the renal function is going to continue to decline. And a lot of this is due to the fact that amphotericin is going to get eliminated renally. And as amphotericin starts to mingle with the renal epithelial cells, in particular at higher concentrations over time, that amphotericin is going to lose its selectivity for ergosterol, and it's going to start interacting with cholesterol in the renal tubule cells. And that's going to lead to renal tubule death and then an increase in then serum creatinine. To circumvent that, or to get around this renal toxicity, a lot of different derivatives have been synthesized over the years, and these lipid-based formulations of amphotericin have actually decreased the incidence of renal impairment. Bless you. So these are what you're going to actually see being used today for the most part to treat a systemic fungal infection if a clinician wants to use an amphotericin derivative. There's Abelset, Ambisome, and then Amphotec. I'm familiar with Abelset and Ambisome. I can't speak to whether or not Amphotec is still clinically relevant. It all depends on your hospital's formulary. You're not going to keep all three. You're just going to pretty much have one lipid formulation on formulary. Nonetheless, they all have the same concept. Let's take amphotericin, this toxic molecule, and mix it in with either a liposome or some other type of fat to help, number one, increase fungal cell mingling, increase fungal cell interaction, decrease renal exposure, decrease renal toxicity. That's the overarching goal of these derivatives. And they work. They actually do a better job at decreasing nephrotoxicity associated with conventional amphotericin. The other problem with conventional amphotericin B is that patients who received it often had a lot of infusion-related reactions. So amphotericin in its conventional form had the propensity to increase the release of cytokines, for example, secondary to its presence in the body. Increased cytokines that can lead to fever, chills, rigor, and other infusion-related reactions. You can prophylact against all that by giving the patient maybe some Tylenol, give them some Benadryl, maybe even a little touch of steroid to help reduce that. We don't see those infusion-related reactions nearly as often with the lipid formulations as compared to the conventional amphotericin. So it also helps to prevent that as well. Right. And then that's amphotericin. Okay. Now this is where I bug Dr. Lewis and ask her annoying questions. When's the last time you saw amphotericin used in your practice? It's been a while.
So, couple months
ago. So it's not used frequently. We have better drugs that are probably less toxic that have supplanted amphotericin. I'd be curious to hear if you remember what they were using it for. Sorry to put you on that spot. You knew it was going to happen. Thank you. Yeah, so we'll talk about Cryptococcus in a little while. All right. Questions about amphotericin? Excuse me. All right. Let's move forward then and shift gears. We'll get away from the fungal cell membrane and talk about nucleic acid synthesis. So being similar to humans, the fungal metabolism is very, very comparable. Again, same enzymes, same substrates, same pathways with regard to macromolecule synthesis. So it's kind of difficult to identify molecules that target very, very subtle aspects of the fungal cell metabolism. However, there is an enzyme in fungi called cytosine deaminase. We have cytidine deaminase. Fungi have cytosine deaminase. So cytosine is just the base. Cytidine is the base plus the sugar. The fact that fungi have a cytosine deaminase allows us to think about using a particular molecule which might get converted into a toxic derivative secondary to exposure to cytosine deaminase. So cytosine, and I'll show you in a minute, has an amino group up at the 6th position. And deaminase enzymes basically take that amino group and convert it to a carbonyl group. So when we do that in cytosine, we actually convert cytosine to uracil. And since we lack this enzyme, maybe we can exploit the presence of this enzyme in fungi for the generation then of a toxic molecule, which might impact fungal cell metabolism. We do that with the drug called flucytosine. Right? And flucytosine, as the name suggests, is a fluorinated derivative of cytosine. It's a pyrimidine derivative, and it tends to be relatively selective for fungi. And so if you bear with me through this really, really quick, this is what flucytosine looks like in the capsule form. Yeah, it's a capsule. It's an oral formulation. And flucytosine exists as this fluorinated pyrimidine. After oral administration, the drug will distribute and ultimately encounter an enzyme that's embedded in the fungal cell membrane called permease. Permease is this enzyme that likes to grab onto flucytosine and pull it into the fungal cell cytosol. Permease will shuttle flucytosine into the cell such that it's in the cytosol now. And in the cytosol, flucytosine can encounter that fungal deaminase enzyme, cytosine deaminase. And fungal cytosine deaminase will convert the amino group to a carbonyl group. And we're basically taking a cytosine and making a uracil derivative. Okay. What we have created inside the fungal cell is a molecule called 5-fluorouracil. And some of you may recognize that immediately as a chemotherapy drug that we use to treat a variety of malignancies in cancer patients. What we've done by doing this is we have selectively created or formed a highly toxic chemotherapy drug inside a fungal cell. And since the fungi have similar machinery relative to the human, this 5-fluorouracil is going to go on to exert a similar mechanism of action that we see in patients being treated with chemotherapy. 5-fluorouracil is going to get metabolized a couple times into a molecule that we refer to as 5-fluorodeoxyuridine monophosphate. The name really isn't important right now, you guys. What I really want you to understand is that this metabolite of 5-fluorouracil has the ability to inhibit thymidylate synthase. It can also compete then with UTP for the incorporation into messenger RNA. So it can disrupt protein synthesis as well. Principally, though, the inhibition of thymidylate synthase is paramount for this drug to work. Inhibiting thymidylate synthase means that you induce a thymidine starvation in the fungal cell. And inducing thymidine starvation suppresses DNA synthesis. And if you suppress DNA synthesis, the fungal cell will ultimately die. Okay. Does that make sense? It's kind of a cool concept, but it's not perfect. Resistance crops up very, very quickly, especially when this drug is used as monotherapy. So as a result, we never ever use flucytosine as monotherapy. It's always paired with something else to avoid the formation of resistance. Where can we use flucytosine? Even though it's approved for use in Candida infections, you'll never see it for that. But what you will do is you will see flucytosine used in combination with amphotericin for the treatment of cryptococcal infections, in particular cryptococcal meningitis. And from a resistance perspective, you could predict this. If you have defective permease enzymes on the surface of the fungal cell that doesn't recognize or want to take up flucytosine, you'll decrease the accumulation of the drug inside the cell, and it won't work. Mutated cytosine deaminase. If the deaminase enzyme fails to recognize flucytosine as a substrate, it won't get converted into 5-fluorouracil. If it doesn't get converted, it's not going to inhibit thymidylate synthase. And then uridine monophosphate pyrophosphorylase. Again, too, this is the enzyme system that is responsible for converting uracil into those uridine derivatives. So this is what adds on the sugar and the phosphate. And if you have defective or mutated versions of this enzyme in the fungal cell, it can't convert the 5-FU into the nucleoside that needs to be formed in order to exert its inhibitory effects. Okay. So that's what I want you to be familiar with. This bone marrow suppression concept. Usually a patient's going to only be on flucytosine for about 2 weeks in combination with amphotericin as part of what we would call induction therapy for cryptococcal infections. But for patients that might be on it a little bit longer, some therapeutic drug monitoring might be warranted. There's been instances where patients who can't tolerate flucytosine and start to develop some cytopenias have been discovered to have bone marrow suppression secondary to higher concentrations of flucytosine. And really what's happening there is the active drug is getting into the bone marrow and actually killing off bone marrow cells. So it's a possibility, albeit rare. So that's flucytosine. So we talked about amphotericin. Amphotericin is a poly-E antifungal that disrupts membrane function and creates pores in fungi. And we just got done talking about flucytosine. Flucytosine gets converted into 5-fluorouracil, which then goes on to inhibit thymidylate synthase in fungal cells to deny the fungi thymidine, suppresses DNA. We'll stop here and take a break, and we'll pick it up with ergosterol modulation when we get back. Okay, so we left off here with ergosterol. Remember, ergosterol is the principal sterol that fungi use for membrane support and function. Our counterpart, of course, is cholesterol. And it's reasonable to suggest that if you were to certainly decrease ergosterol content in a fungal cell, that's going to have a profound effect on the viability of that fungal cell. But what if you don't necessarily decrease the overall content, but maybe change something in the ergosterol such that it's not proper ergosterol, it's an aberrant ergosterol or a methylated ergosterol? What's been discovered is that if you generate methylated ergosterol derivatives secondary to the administration of a particular class of drugs, that still has a fungicidal effect on certain fungi. Now, when you look at ergosterol and cholesterol synthesis, their biosynthetic pathways are almost identical. Okay, what really differs is where it's happening. And then when you get to a certain branch point, fungi go in one direction, humans go in another direction, and that's where the difference really exists. I'm not going to make this a cholesterol or ergosterol synthesis lecture. That goes beyond the scope of what we're trying to do here. But I do want to introduce and emphasize two important enzymes that are present in these pathways. The first one is an enzyme called squalene epoxidase. And then the second one is referred to as 14-alpha demethylase. And that also goes by the name CYP51. So it's a cytochrome enzyme. Okay. These two enzymes are critically important in the synthesis of ergosterol and cholesterol. So it's reasonable to think if you can have a small molecule that impairs the activity of one or both of these enzymes, in particular in a fungal species, you're going to shut down ergosterol synthesis. And that's the overarching goal of the azole antifungals. And then the allylamine derivative, terbinafine, is an inhibitor of squalene epoxidase. So what does that look like? Well, up here in the top left, you don't have to write anything down here if you don't want to. I'm not going to test you on this part, but up in the top left is squalene. And squalene is the result of polymerization of multiple isoprenoid units that typically occurs in your liver, in the fungal cell as well. And when you polymerize these isoprenoid units, you end up with this linear unsaturated molecule called squalene. And squalene has the ability then to start folding on itself, right? And it ultimately ends up looking like it does up in the top left. And then under the direction of an enzyme called squalene epoxidase, an oxidation reaction will occur that will oxidize this double bond, creating the epoxide. And then epoxides are highly strained heterocycles. They want to open up. And what ends up happening is that the pi bonds on a neighboring area of unsaturation in squalene end up attacking and opening up that epoxide. What that does, though, is that catalyzes then this whole intramolecular attack or rearrangement reactions. Yeah, you can see how it all of a sudden starts to fall into place. So you get this, and then you get this, and then you get this. And what you end up with after all of the attacking and bonding has occurred is the formation of an intermediate then called linosterol. Okay, so the presence of squalene epoxidase and the resulting intramolecular rearrangement is critical for the formation of linosterol. Right then and there, you can see why it would be beneficial to inhibit this particular enzyme with a small drug molecule like terbinafine. Okay. However, as we go forward, we made linosterol. Linosterol is going to undergo a variety of different reactions. And ultimately, though, linosterol is going to serve as a substrate for an additional enzyme called 14-alpha demethylase, right? 14-alpha demethylase. And in this two-dimensional representation up on the screen, the red arrow is pointing to a methyl group in the alpha configuration at the 14 position on linosterol. And the goal of this particular enzyme is to oxidatively remove that methyl group. And once that methyl group is removed, then the subsequent steps in the formation of linosterol can occur. Right? And then you have proper functioning ergosterol that gets embedded in the fungal cell membrane. Now, what happens under the influence of azole antifungals like diflucan or fluconazole is this enzyme is inhibited. And when we inhibit this enzyme, we basically skip this step in a fungal cell. That demethylation reaction doesn't occur. You start to accumulate then linosterol derivatives with that methyl group at the 14 position. But rather than this being a bottleneck, rather than everything stopping right here, it continues forward. Right? You get so much substrate that it overwhelms the system and it continues forward. The fungal cell will continue to metabolize and ultimately generate then ergosterol derivatives that retain that methyl group at the 14 position. So the literature and myself and others will refer to those as aberrant ergosterols. They're unique, inappropriate ergosterol derivatives, and they actually do damage to the fungal cell membrane. So the fact that this can commence and move forward is actually not a bad thing, because what we're doing is we're generating toxic ergosterol derivatives that do damage to the cell. Just a little background here. The azole antifungals have been around for a long, long time. Their inspiration came from benzimidazole derivatives that were noted to inhibit certain fungal growth, in particular in the agricultural industry. So if you look at a benzimidazole derivative, here's the benz and then here's the imidazole component. A simple molecule like that has the ability to inhibit certain fungal metabolism. And then when you take this and start applying it to the structure of the molecules I'm going to show you in a moment, it starts to make sense, in particular the imidazole component, okay? A lot of these derivatives that were initially synthesized, in particular by Janssen Pharmaceutical, who at the time were the leaders in azole development, they were way too lipophilic. You can take them orally, but they just aren't going to get into solution in the gut. They're not going to get absorbed because they can't go into solution, and you just pass them right out. They were way too lipophilic until we arrived at this molecule called ketoconazole that was mentioned earlier, or nizoral. So nizoral tablets and nizoral or ketoconazole represents then the prototypical azole antifungal that was first available for fungal infections, and it's an imidazole derivative. Ketoconazole is fraught with drug interactions and other adverse effects. It's really not that great of an antifungal for systemic therapy. As such, other derivatives have been synthesized and basically supplanted ketoconazole for the treatment of systemic infections. Those include itraconazole or Sporanox, if you're familiar with that. Everybody's familiar with diflucan or fluconazole, Vfend or voriconazole, posaconazole, Cresemba, which is isuvaconazole. These have all now been approved by the FDA for the treatment of various fungal infections. And it just kind of gives you a sense for what's available just orally, and then what's available both intravenously and orally. When you look at the structure of the azole antifungals, of course, the azole component is referring to the nitrogen heterocycle that's embedded in all the derivatives. And the number of nitrogens initially was 2, so we had imidazole derivatives that you saw with ketoconazole. The contemporary azole antifungals are triazoles, so they have 3 nitrogens in a 5-membered system. But there is an additional molecule that was approved not too long ago, oteseconazole. This is actually a tetrazole derivative, so there's 4 nitrogens in a 5-membered system that was recently approved. But it's, again, it's only indicated for recurrent vulvovaginal candidiasis, so I wouldn't expect to see this used for anything else in the near future. Regardless, the triazole moiety that is seen in the contemporary azole antifungals allows these drugs to bind with high affinity to this CYP51 enzyme, or 14-alpha demethylase. When they make their way into the active site of the cytochrome enzyme, the lone pair of electrons on one of the nitrogens is forming what we refer to as a dative bond with an iron molecule in the active site of the enzyme. And then that forms a very, very strong interaction to basically shut down the enzyme for a prolonged period of time. So the azoles, the triazoles, form a very strong bond with the heme iron, okay? when I'm just kind of curious, when someone says a cytochrome enzyme, and you try and think, what does that actually mean? What is a cytochrome enzyme? What does a cytochrome enzyme look like? What's your concept of a cytochrome enzyme? Have you really looked at it in any detail? I mean, if I said draw out your concept of a cytochrome enzyme, where would you start? So I just want to take a second to get everybody on the same playing field, if you will. These are heme-containing enzymes, right? And they're of varying size and they have varying substrate specificity. By far the most, I don't want to say promiscuous, but the most accommodating active site is seen in CYP3A4, okay? In CYP3A4, you can just think of it, there's this big active site, right? And within this active site, you've got all of these pyrrole and pyrrolidine derivatives that are forming what we call protoporphyrin. And then at the center is the iron, which basically is making up heme, okay? And then this heme group is attached with the cysteine residue. And then really what you see up at the top above in this area is the access point, is what I'll call it. All right, so I'm going to erase this. So this is where the business end is going to occur in a heme enzyme. And you guys, I'm not going to test you on this. I see people writing stuff down. If you want to write it down for your information, that's fine. But just kind of hear me out, okay? Now, in its ground state, that iron isn't oxidized, okay? So it's probably most likely a ferric iron. It's probably got a +3 oxidation state. All right, after oxygen and NADPH come in, what you're going to end up with is an oxidized iron. All right, it's called a perferyl iron, and it's got a +5 oxidation state. This is a very, very potent oxidant. And this species that you see here on the screen has a high capacity then to oxidize drug substrates, okay? So when you talk about CYP enzymes oxidizing drug molecules to first engage in a phase 1 reaction where you put the hydrophilic molecule on the drug substrate, this is what's happening. That oxygen is being transferred over into your drug molecule, right? And it's an oxygen like this that's getting transferred over into that methyl group at the 14 position on lanosterol a couple times, such that it leaves as an equivalent of formaldehyde and creates an area of unsaturation in lanosterol, okay? What we really want to do, though, with regard to antifungal therapy, you put one there if you want. So this is supposed to be a triazole up here. That triazole in your antifungal agents is replacing the oxygen, and it's forming this very, very tight bond between CYP51 and itself. And by virtue of the drug, you can say fluconazole if you want. By virtue of fluconazole in the active site tightly bound to the iron, number one, it's inhibiting the enzyme. Number two, it's there. And if fluconazole is there, lanosterol can't be there. So it's blocking the enzyme active site as well. And it's shutting down then that demethylation reaction. Okay? Questions about that? So again, too, here's your enzyme active site. There's your iron. Here's your lipophilic binding pocket, your access point. This is where lanosterol would like to bind. When lanosterol binds, the methyl group is going to dangle and get oxidatively removed. That's what the fungi want to do. But when we put a drug like, here's voriconazole binding to the active site, the triazole is binding very, very tightly to the iron in heme, shutting the enzyme down. That's the goal right there. So azole antifungals inhibit CYP51. Right? They increase the concentration of lanosterol derivatives that retain the methyl group. Those aberrant sterols get implanted in the cell membrane. They cause disruptions in membrane function, and that leads to then, fungicidal effects, fungal cell death. You see permeability changes, leaks, protein activity, and so on. Okay. The only thing I'm really going to say about structure activity, obviously the triazole component of these drugs is critically important for their activity. A triazole is more basic than anamidazole. I'm not going to tell you that a tetrazole is more basic than a triazole. It's not. But nonetheless, the higher the basicity in the triazole, the more availability then of those electrons on the nitrogen, which lends to a tighter bind. Okay. The side chain that's attached to the triazole moiety. This is where the variability exists in the drug molecules. And certain side chains have higher affinity for certain CYP51 enzymes from species to species. By way of example, fluconazole binds very nicely to Candida albicans, right? But fluconazole will not bind to Aspergillus CYP51. It binds very nicely to albicans CYP51, but it has no affinity for Aspergillus CYP51. And contrary to that, voriconazole will bind to albicans CYP51 and it will bind to Aspergillus CYP51. So it's a big difference between the two. And so just understand there's a lot of variability on these side chains, which binds additional areas of the lipophilic pocket. And if you see a drug that has, in particular, a triazole moiety on it, that should give you a clue all of a sudden that it's going to have affinity for a CYP enzyme. Fluconazole, diflucan, IV, and PO, it still ends up being a mainstay of parenteral antifungal therapy in the hospital. Yeah, it still retains activity against Candida, but honestly, today, the only thing that you should really be using diflucan for is Candida albicans. And when somebody is identified as having a Candida infection, in the blood or a different source, if you have histological confirmation of Candida, it needs to be speciated. We need to know if we're dealing with an albicans or a non-albicans Candida because it's going to greatly influence drug therapy. Right? Albicans is by far the most common, but other Candida are starting to appear more often in the hospital setting. So we need to speciate to make sure we get the right drug on board. Fluconazole is used for cryptococcal infections as well, in particular in the consolidation and the maintenance phase of cryptococcal meningitis. It does cross the blood-brain barrier and it still does retain activity against cryptococcus. Hopefully you're starting to realize that due to the nature and the structure of these drugs, these azole antifungals, they do a nice job of inhibiting CYP51 in fungi, but they do an extraordinary job of inhibiting CYP enzymes in your liver. Yeah, some of them are far more offensive than others. Fluconazole will inhibit CYP2C9 and 3A4. So whenever you see an azole antifungal ordered you just got to expect a drug-drug interaction. It's going to happen. Voriconazole or VFend, again, PO and IV. It's very similar in structure to fluconazole. I think the only difference really is a pyridine ring. Spectrum of activity, again, VFend will address Candida, but its claim to fame, and probably the reason why it got approved, is because it has activity against a variety of aspergillus. So you can treat aspergillosis with voriconazole. Other notable attributes for voriconazole: it tends to have activity against resistant strains of fluconazole. Certain Candida species that are resistant to fluconazole will retain susceptibility to voriconazole. VFend is very, very notorious for causing drug-drug interactions. So again, I personally have never dispensed voriconazole that I remember. I think that's something that you would recall if you do. I don't know if you have experience with voriconazole at your institution, but there's a lot of drug-drug interactions that you're going to have to screen for, and you have to make decisions sometimes. What's more important? Do we keep the patient on this statin, or do we stop the statin so we can give the voriconazole to cure the patient of their life-threatening fungal infection, and so on? A relatively newer azole antifungal, Cresemba, or isobuconazonium sulfate. This is a prodrug. So isobuconazonium sulfate or Cresemba is available in an oral and an intravenous formulation. And after oral or intravenous administration, enzymes in the plasma will actually hydrolyze off a component of the drug to afford us with isobuconazole. And it too is a triazole, so its activity is, or mechanism is, as expected for all other azole antifungals. Cresemba is noteworthy for the fact that it does have activity against aspergillus, but there's another nasty mold called mucorales, or mucormycosis. Mucorales is a devastating fungal infection, and individuals who get exposed out in the environment will start to develop a lot of tissue destruction secondary to mucorales infection. We don't have a lot of drugs that actually treat mucorales. Isobuconazole is one, posaconazole is another, and then amphotericin B is a third that can be used for mucorales infections. I wouldn't say now, but when you get a second, just to appreciate how devastating this particular fungal infection is, just type in mucorales or mucor infection in Google and hit images, and then that'll give you an appreciation for how bad this is. Patients often need a surgical debridement of the areas where the infection occurs, and it's very disfiguring. Again, fortunately, we don't see this all that often. A lot of times it crops up after natural disasters, hurricanes, and things like that, getting kicked up from the environment. Again, too, as an azole, you would expect certain drug interactions to occur. And then there's just a picture again. The generation of these aberrant or toxic sterols secondary to azoles creates leaks and dysfunctional membrane function. Yep. Questions about the azole antifungals? I'm just going to go through allyl amines very quickly. The only allyl amine that is currently available in an oral form anyhow is terbinafine or Lamisil. Again, too, it's an inhibitor of squalene epoxidase, and that was the enzyme that initially oxidized squalene to catalyze the formation of lanosterol. Inhibition of that enzyme decreases the concentration then of lanosterol in a fungal cell, it also significantly increases the concentration of squalene, which in and of itself can be toxic to fungal cells. I will be honest, the only time that you really see this is for onychomycosis or toenail infections. It had been studied as consolidation therapy or I guess salvage therapy for certain types of fungal infections, Aspergillus in particular. And those results never led to a secondary indication for terbinafine. So have any of you guys ever dispensed Lamisil tablets? Are you familiar with it? Do you see it at all? Not so much. Yeah. I think the lacquers and the polish has replaced this a lot. Causes a lot of headaches from what I understand. All right. And then that takes us to the fungal cell wall. So beta-1,3 and beta-1,6 glucan are the most common polymers of glucans in the fungal cell wall. And beta-1,3 glucan is by far the most prevalent. And these glucan polymers are synthesized by an enzyme called beta-1,3 glucan synthase and beta-1,6 glucan synthase. Fungi typically express both enzymes. However, beta-1,3 glucan synthase is the major enzyme that's responsible for putting together the fungal cell wall. So beta-1,3 glucan polymers represent the majority form in the fungal cell wall. And again, shape and stability is the overarching goal of the fungal cell wall. So it's reasonable to think if we can inhibit this somehow, cell wall integrity and stability is diminished. Much like with bacterial cells, you'll see lysis secondary to a compromised bacterial or fungal cell wall. The identification then of those enzymes, coupled with the identification of naturally occurring substances, led to the identification and then the development of the echinocandin class of antifungals. The echinocandins represent lipophilic hexapeptides. They have the capacity to non-competitively inhibit beta-1,3 glucan synthase, thereby compromising the integrity of the fungal cell wall. Right now, we have actually 4 derivatives clinically available. Caspofungin is the prototype. That was the first one that was approved by FDA way back 20 years ago, perhaps. Micafungin, and then anidlufungin has also been approved. And then resifungin is the most recent entry into the echinocandin class. This particular one is noteworthy because it's got a prolonged half-life. Evidently, it binds to albumin for a very, very long time, such that you only have to give it q-week. So it's a once-weekly administration. Has demonstrated curative for candidemia and then invasive candidiasis. But do you think it's used? Not yet. Pretty expensive. All right. So let's talk about a couple of these drugs briefly. Caspofungin, again, too, its inspiration was a molecule that was discovered a long time ago called echinocandin B. That was a naturally occurring substance that was unfortunately just too lipophilic to administer in a parenteral form. As such, it never got developed, but it did provide the inspiration for a drug like caspofungin. You have to typically give these drugs intravenously because they are cyclic hexapeptides. So the acid and then the enzymes in the liver will degrade the drug into a linear form, thus inactivating them if you give them orally. So we can't do that just yet. Caspofungin and its counterparts can be used for empiric antifungal therapy in a neutropenic patient. So when patients have neutropenia, and they have antibiotics started, and the antibiotics aren't necessarily doing the trick, you really need to start scratching your head and ask yourself, okay, do they perhaps have a fungal infection? Can we detect fungi in the blood? And if we're worried about that and we want to start something, we're given an echinocandin empirically until otherwise proven to not have a fungal infection. Esophageal candidiasis. HIV patients often present with this, especially those that aren't taking their antiretroviral therapy. So it carries an indication for that. Invasive aspergillosis. Refractory patients or patients unable to tolerate other therapies. Drug of choice today is still voriconazole for aspergillosis. But if you have a patient who has toxicities associated with voriconazole, adverse effects or drug interactions that preclude the use of voriconazole, an echinocandin could be a suitable replacement. So here's the structure of caspofungin. And again, too, you'll notice its cyclic nature. That cyclic nature is made possible by the formation of multiple amide bonds, amidases, hydrochloric acid, other things like that that are found in the body will break that down. So we have to give these drugs intravenously. And then caspofungin, much like its counterparts, have a lipophilic tail. The FKS gene encodes the enzyme that's responsible for synthesizing fungal cell wall. And that enzyme is embedded in the plasma membrane of fungi. And that lipophilic molecule helps to anchor then the drug in the membrane to keep it where it's needed for purposes of inhibiting the enzyme. Mycofungin, you made mention of earlier, again, too, mechanistically does the same thing, inhibits beta-1,3-glucan synthase. It too is a cyclic hexapeptide. It's got a lipophilic anchor. Anidulufungin, again, Araxis is the trade name, just another echinocandin. What varies between these derivatives, anidulufungin and then mycofungin, is largely then the lipophilic tail. Okay. And then I made mention of rezafungin. Rezafungin, again, is a newer, long-acting echinocandin. The lipophilic anchor seen in rezafungin is virtually identical to that seen in anidulufungin. This trimethylamino group with a permanent positive charge is where this drug gets a little bit wonky. And evidently that then helps to adhere to plasma proteins, which then prolongs its half-life significantly. So you think about that. You have a patient who has, perhaps they have a candida endocarditis or a deep-seated candida infection. They get stabilized and they're good enough to go home, but you got to bring them back every single day for their antifungal therapy. All right, so that's a huge burden on the patient and then the healthcare system. Conversely, what if you can just give them a dose today of rezafungin and send them home and then have them come back in a week and give them a dose of rezafungin, and then perhaps that's it. I mean, is the cost of the drug or the cost of daily administration, travel, nursing time, etc., where's the balance there? What is the real judicious use of the healthcare system? I don't know. Just makes you scratch your head. Nonetheless, manoproteins, beta-1,6, beta-1,3, that's what things look like perhaps in an untreated fungal cell wall. But when you add on an echinocandin, you can see the profound loss of the beta-1,3 linkages in the lower image. So that's what is actually causing the fungal cell death, right, secondary to a drug like caspofungin. Okay. All right. Cryptococcus. Cryptococcus neoformans is a yeast. It's an encapsulated yeast that has a tendency to infect immunocompromised individuals, in particular your HIV patients. Echinocandins do not cover Cryptococcus. right? I think it's important just to understand that echinocandins have their place in therapy. They're good for candida, drugs of choice for candida infections. They can be used for aspergillosis. But when we talk about cryptococcal infections, these drugs do not work for cryptococcus. And what's interesting is cryptococcus still does make beta-1,3 glucans. It does have a 1,3 glucan synthase. Echinocandins will inhibit that 1,3 glucan synthase, but what they think is going on is that cryptococcus makes such a large layer of chitin, and it has a more dependence on 1,6 glucans, that the inhibition of beta-1,3 glucan synthase is clinically insignificant for this particular species. Okay. As we progress through these very quickly, you'll notice that there are some slides that have a different background color. Those are the slides that you're going to want to focus on for the purposes of the final exam. I will expect you guys to be able to select the right choice for the treatment of Candida, for the initial treatment of aspergillosis, and then the initial treatment of Cryptococcus. Okay. Risk factors and treatment. Okay. So again, when we talk about invasive fungal infections, you have a bloodstream infection or you have a deep-seated infection where the fungus is actually invaded and growing in one of the organs. It can be a primary pathogen, Candida, aspergillosis. It could be opportunistic, Candida, aspergillosis. It could be endemic. Without a doubt, immunocompromised individuals are the most often noted as having these types of infections, invasive fungal infections. And those three at the top there, Candida, Cryptococcus, and Aspergillus, those are the ones we're going to focus in on. When you talk about Candida, again, as I suggested earlier, it's a normal inhabitant of the GI tract, of the skin, and other areas of the body. Candida albicans is still the king. It's still going to cause about 80% of all Candida infections. But Candida glabrata, Candida parasaplosis, tropicalis, and then cruzi are starting to become more frequently identified as Candida infections. And if you remember earlier when I said you really need to speciate the Candida to help guide treatment, it is important because most Candida albicans are still sensitive to fluconazole. And when you hear Candida, the knee-jerk reaction in the hospital might be fluconazole. But if you come to realize that it's a glabrata or a cruzii in particular, if you have one of these variant Candida species causing the infection, the fluconazole is an inappropriate choice. You need something different to treat the infection. So that's why speciating is important. Who gets Candida infections? Not surprisingly, HIV patients who have a very, very depleted CD4 count, individuals who have solid organ transplants. In fact, Candida is very common in those folks. Individuals with a hematologic malignancy, stem cell transplant again. So those are the sorts of folks that you're worried about with regard to Candida. And we did make mention of some other risk factors early on: central venous catheter, TPN, broad spectrum antibiotic use. Abdominal surgery in particular. How do you diagnose? Again, too, if you can isolate the Candida from the blood, usually the white cells endocytose the Candida, so they have to break open the white cells to actually get the Candida from a blood culture. You can grow it, though, on a dish. You can do a microbroth dilution. You can isolate and grow Candida. Histopathologically, if you get a specimen from the patient, you can identify it there. You can see it in the urine. Mucocutaneous infections, mouth, pharynx, even a vaginal yeast infection, again, just clinically by seeing it. There are some more sophisticated techniques that can be used to help then identify perhaps the presence of a Candida infection. There's an assay called the Fungitel assay, and the Fungitel assay has the capacity to detect beta-1,3-glucan from a serum sample. The problem with that assay is that it's not 100% specific for just Candida, because there's other species out there or other fungi that make 1,3-glucans, Aspergillus and Pneumocystis in particular. So the Fungitel will tell you, yes, you have a fungal infection, but it doesn't have the ability to tell you that it's Candida albicans or Candida krusei. If you want to speciate it, you probably need to do PCR reaction. Treatment of invasive candidiasis. The preferred drug still today is an echinocandin. Which one? Well, which one do you have on formulary? Okay. And this is going to be preferred for most patients, both neutropenic and non-neutropenic. Caspofungin, 70 milligrams day 1, and then 50 milligrams daily thereafter is the FDA labeled indication for patients that are below 70 kilograms. I think if you're above 70, it's 70 milligrams daily. Right? If you're on a CYP3A4 inducer, it's 70 milligrams daily. Micafungin, 100 milligrams once daily. Nidlefungin, 200 times 1, and then 100 milligrams daily thereafter. And so those are the doses that you would use. Of course, source control is important. If you can identify where the fungus is from, if there's a nidus that you need to address, you do that if possible. If you're certain that you're dealing with an albicans Candida and you don't have a critically ill patient, bless you, you could use diflucan or fluconazole as an alternative to an echinocandin for the treatment of that patient. We typically do this for about 2 weeks from the first negative blood culture that's drawn. Okay. If the eye is affected, a lot of times Candida can infect the eye, get into the vitreous, and if that's noted, it's a little bit longer, and that actually might involve them injecting antifungal drug directly into the eye because blood penetration there is very, very poor. Okay, so make sure you're familiar with this slide. Cryptococcus, again, too, this is an encapsulated yeast that's pretty much ubiquitous. It's found pretty much everywhere. Before antiviral therapy for HIV, I mean, you would see this quite frequently in HIV patients. Years ago, we would dispense Bactrim and diflucan tablets to our patients with HIV to prophylax against Cryptococcus. We don't have to do that anymore because the best prophylaxis against cryptococcal infections and many other opportunistic pathogens in HIV patients is just making sure that the CD4 count is above 200. And nonetheless, HIV patients, solid organ transplant recipients, stem cell, and patients with various leukemias are at increased risk for Cryptococcus. Cryptococcus can cause meningoencephalitis. It can cause a meningitis, but it really can cause infection anywhere in the body. And you can culture Cryptococcus. You can actually just get a cryptococcal antigen level. That's probably the easiest way to identify and confirm cryptococcal infection. And then lumbar puncture as well. Sometimes these individuals with cryptococcal meningitis have an elevated opening pressure, and that elevating opening pressure persists for some time. So how do we treat cryptococcal meningitis and cryptococcal infections in general? It basically involves 3 stages. So individuals that are diagnosed as having cryptococcal infections, cryptococcal meningitis, we start them off on induction therapy. Induction therapy typically lasts around 2 weeks, and it involves the administration of 2 drugs. We're going to use an amphotericin derivative, and then we're going to use that flucytosine agent that we made mention of last hour. These are going to be used in combination. I think what's preferred is going to be a liposomal derivative, liposomal amphotericin, 3 to 4 mg per kg, or lipid complex, 5 mg per kg daily, plus 25 milligrams per kilogram of oncobon or flucytosine daily. 100 milligrams per day is what it boils down to per kilogram. And we do that for a minimum of 2 weeks. So you combine amphotericin and flucytosine for 2 weeks. After 2 weeks, we can switch therapy to this consolidation phase, which is going to last anywhere from 8 to 10 weeks. And this simply involves the administration of fluconazole, anywhere from 400 to 800 milligrams daily, depending on the patient. And that's going to continue for a couple months until we get to the maintenance phase. And the maintenance phase is going to continue until we get to 1 year's total of therapy. And the maintenance phase is going to involve anywhere from 200 to 400 milligrams of fluconazole administration daily. Right? So cryptococcal meningitis, for example, is a protracted treatment regimen. 2 weeks of induction, 8 weeks of consolidation, and then up to a year then of maintenance. All right.
You mentioned that if you look at amphotericin B dosing, liquid formulation, we use it much higher than 4 or 5 times higher. The conventional dose is much lower, right? 0.71. So usually the hospital will carry conventional formulation and one of the liquid formulation. When you receive the order, the pharmacist will we want to check is the making sure we have right drug and the right dose. So we want to verify the dose and the right formulation. So there was an incident, the physician ordered conventional dose with a liquid conventional drug and then liquid dose. And then accidentally pharmacist verified expensive to patients causing significant nephrotoxicity. Making sure you check the drug and the right dose.
Thank you. And then lastly, I'll just make mention of Aspergillus. This is an environmental mold, and like Cryptococcus, it's ubiquitous. I mean, you go outside today on a beautiful day like today, you take a deep breath, you're probably inhaling some Aspergillus in some way, shape, or form. Why you don't get sick? Because you have an intact immune system, okay? There's the various species of Aspergillus. Fumigatus is probably the most common. The same patient population is at risk for Aspergillus that we saw with, Candida, that you see with Cryptococcus. And again, too, though, it is very pervasive, though, in your transplant recipients, in particular those with lung transplantation is really a risk factor for Aspergillus. This is what I would like you to review and become familiar with regard to Aspergillus. Right? Still today, as I checked over the weekend, voriconazole is still recommended as the drug of choice for initial treatment of aspergillosis. I will say that there was a study done not too long ago that compared isavuconazole to Aspergillus, and it was deemed to be non-inferior, so it's equivalent to voriconazole. It's just a matter of that point, which one do you want to go with? I know voriconazole is fraught with a lot of adverse effects, central nervous system effects, vision effects. They both carry risks for drug-drug interactions. If one is tolerated better than the other, that's the one that's ultimately going to rise to the surface. But for now, when you hear aspergillosis, you probably should be thinking voriconazole until proven otherwise. Okay. All right. Well, that's all I have for today. On Wednesday, we will, like I said, I'll be here at 8:15 on Wednesday. If anybody wants to talk, and then we'll begin our studies of HIV.